Thank you, Dr. Ellen. Good morning, ladies and gentlemen. Welcome to everyone remotely on this wonderful spring day. I think we finally broken the temperature above zero for once this year. Let's get going. Okay, what I wanted to talk to you about today is opioid use, because there is some controversy about the issue of opioid use throughout medicine, and specifically in older adults. Oops. Firstly, I just want to say I have no conflict of interest to declare, and all my research and preparatory work for this presentation was not funded by anybody. So back to the question, opioid use in older adults, is it a good idea? And the simple answer, and if you really wanted to leave early and go do something else this morning, absolutely, when appropriate. So there you go, that's the message. Now I'm going to go further into why I think it's appropriate and what the evidence out there in the literature says about this particular topic. Here's one of my rules. If the mayor of New York City gets into an issue, you know it has to be important. So here you have, this is a clip from the Journal of the American Medical Association, and this is March this year, Improving Opioid Prescribing, the New York City Recommendations. So New York City said, and Michael Bloomberg had a big press release about this, that there's a big problem with opioids in New York City, and we have to do something about it. Is this big news? Of course it is, because he says so. So let me go into some of the background of all this. In the very beginning, there were these innocent-looking poppy plants, and someone decided, well, the stuff that's coming out of there, well, let's taste it and see what happens. Anyways, they got quite happy with these plants. So this is your opium poppy, and it's been around a long time. So here's an old vial of elixir of opium. So when you distill the stuff that comes out of these opium poppies, you get various compounds. You can have it dried, you can have it liquid, etc. And morphine is the most abundant opioid substance in the extract of these poppies. So just think about it the next time you see these nice poppies, right? How much happiness you can derive from them, not just visually. Opioids are probably one of the most powerful analgesics we have in medicine. And they've been around, like I said, a long time. So if you moved a little bit west from those fields in Afghanistan, you land in the cradle of civilization in Mesopotamia. And the Sumerians actually had recorded the first use and probably the first abuses of opioids in way back in 4000 BC or even earlier. So it's been around, and people have just said, here's a good thing. But it's really the Sumerians who actually put it into writing, into etching it into stone. And then finally the compound, as you see here on your right, was isolated in 1804. And of course, once you isolate a compound, you can start playing with it, because the organic chemists have to stay involved, and the pharmaceuticals are very interested in this, to try and modify the molecule, enhance some of its properties, probably control some of its side effects, do wonderful things to its pharmacokinetics so that you can extend its half-life, etc. So this is what we're talking about today, the opioid series of medications. The flip side of analgesia is probably opioid abuse. So the frame in the upper right shows this wonderful daguerreograph of an opium den type setting, very lavish. But as you see, all those individuals would probably score a high chem because they're not exactly that lively. So opioids and narcotics over the years has triggered a lot of crime because of the compound and fighting for it and bartering and trading it. Crime, conflict, wars, addiction, accidental poisonings, etc. And in 2011, 2012, the opioid analgesics were the 15th most prescribed drug class in the world, and it was the third most common drug class prescribed in the US. And in 2012, this is according to IMS Health data, the #1 prescribed pill in the US was actually the combination pill of oxycodone plus acetaminophen. So these things, these global phenomena lead to people raising flags saying, oh my God, what are we doing? There are all these opioids in the world. We're heading into oblivion because of this. So here you have an article in the New England Journal, Flood of Opioids, a Rising Tide of Deaths, and they're saying we have a global, and certainly for the US, it's global and the US, a prescribing or prescription opioid crisis. So what does this mean? Is this what our next step is? We have to lead the charge. We have to stamp this out. We have to control everything. Every opioid prescription will have to be on 10 copies sent to 9 different people, and none of those copies go to the patient. Is that what we're going to end up having to do? Well, the counter proposal is, you see, is the monk, one of his 4 paintings, The Scream, is we have to deal with patients. And our poor patients have this. They have persistent pain. So we have to manage persistent pain as optimally as possible. So how do we reconcile? On one hand, we have opioid prescription that's widespread, that's perhaps in the literature, in the media, and on the other hand, we have this patient in front of us that has persistent pain, that is distressed, needing treatment. So let me push the argument from the other side, from the geriatric side and older adults. Here are some statistics. Yes, we all know that the world population ticked over in late 2011 to 7 billion in the world. And the World Health Organization reports that 11% of them are older than 60. Now, as you know, pockets around the world and countries and areas have a higher percentage than 11%. But if you say globally, 11%, that's about 770 million people over 60 years old. So if you took all of Western Europe, you could replace the entire population by the elderly, right? So that's a lot of people in the world. So if you take that and say many of those people have persistent pain because of their comorbidities, they have arthritis, they have spinal stenosis, they have diabetic neuropathies, they have all sorts of reasons to have persistent pain. And it's 1 in 5 almost. So that's a large portion of people worldwide. And again, in various surveys, 2/3 of people who do have persistent pain are taking analgesics for longer than 6 months. So you put those things together and you say, there's a lot of people with persistent pain, they need analgesics. Oh, and by the way, there are a lot of prescriptions for opioids. So where's the problem, right? It actually may be a perfect match that you are prescribing appropriately, or the number of prescriptions are appropriate. So we just have to make sure that those prescriptions are targeted to the right people. Other thing that, things that are out there, of course, the World Health Organization 3-step ladder for chronic or persistent pain management, and I'll show you that in terms of where opioids and narcotic analgesics are placed. So they're on step 2 and 3. And the American Geriatric Society updated guidelines in 2009 on the management of persistent pain, also includes the use of opioids for pain. So we're treading on very solid ice when we go out and prescribe opioids for our older adults, definitely. So here's the WHO pain ladder. So the state at the bottom, we don't want, right? We want to head up the ladder to make sure they're freedom from cancer and non-cancer pain. This was originally developed for cancer pain, but it certainly has been extended to non-cancer pains now. So essentially, step 2 and 3, when you start to have progression to moderate to severe pains, then certainly opioids are an appropriate agent to use. And here you have, this is the 2009 guidelines, the American Geriatric Society guidelines on persistent pain. And opioid analgesics in properly selected and monitored patients constitute a potentially effective and for some patients indispensable treatment as part of a multimodal strategy in the management of various types of persistent cancer and non-cancer pain. So I think these publications are giving us justification for using opioid analgesics in older people. So back to New York City. Well, what was Michael Bloomberg all about? Well, a lot of opioid prescribing was, especially in the emergency room, was being redirected for illicit purposes. So ER physicians, as you well know, are very busy people, lots of chaos in their emergency room. So when a person comes in and has an acute or chronic pain syndrome and says, well, I lost my prescription for Percocet, can you please give me another one because I'm in horrible pain? Well, they end up doing the humanistic thing and try and order what they think is appropriate. So some of those were being misdirected and not used appropriately. So this is why they came up with these recommendations. So it doesn't say that you cannot prescribe opioids. It's just try and be a little more careful, especially if you're in the emergency room, because the person who's come in to seek health services may not really need the opioids, but is using it or redirecting it for other purposes. So what are the things we have to think about when we're selecting a narcotic analgesic in one of our patients? Firstly, we want to make absolutely sure we have a good handle on pain assessment. Can we actually know how bad their pain is, and can we revisit that and reassess it periodically using one scale or tool versus another? So you'll see these pain scales, 0 to 10, the visual analog scales, thermometers that go horizontally or vertically, that change color. You can have various scales that involve faces, that you see a face that's very happy versus grimacing versus in excruciating pain. There are various tools out there, but you need to at least use one and use it consistently with your initial assessment and reassessment of the patient so that you can know what the pain is at, and you can document it for future purposes. In older patients with cognitive impairment, it can be a little more difficult. And likewise, if you have an intubated patient, how do you get the pain assessment done? There are actually tools that are targeted to the ICU setting and to the cognitively impaired individuals, even down to the level of people with a moderate to severe dementia who are unable to speak any longer. There are tools that allow you to observe the patient trying to do activities and seeing whether they are protecting something, whether they are agitated about the movement, whether they grimace, all sorts of things like that. Those tools have been validated and they are available, and certainly I can lead you to the references if needed. But at least you have to make sure you can assess pain adequately. Other important issues, the patient's kidney function, that's fairly easy to get. So a serum creatinine and an estimated creatinine clearance. Liver function, I put that up there because even in the old, liver function's reasonably intact unless they have other liver disease from either infectious or alcoholic causes. So the format, medication administration is important. Many of these narcotics come in oral format, so tablet or liquid, and or parenteral format, so subcutaneous, intramuscular injections. And lastly, patch formulations, which have been very, very useful. Onset and duration of effects, side effects, you have to be aware, and then when they take it, how long will it be before they have analgesia, how long will their side effects be persisting, etc. Goals of treatment, very important. Drug potency, psychological state, social situation. We certainly do all that in geriatrics, so I don't have to tell you much about that. So I'm going to go through a list of some of the commonly prescribed opioids in geriatric and medicine practice, and just highlight a few good things and perhaps bad things about these particular drugs. Codeine. What I put in the brackets there are potency equivalents. So codeine at 0.1 is 1/10 the potency of morphine. And that's because codeine has to be converted by a liver enzyme, the cytochrome series 2D6, into morphine itself. So codeine, in fact, is a prodrug. It needs to be converted to become morphine and have an analgesic effect. And the reason I need to point out codeine particularly is if you have a case where you try codeine as a mild narcotic and the doses, you keep going up in the dose and you're not getting anywhere, you have to think that this drug is not being converted to an active compound and switch to morphine, because that way you don't need to have it converted, or switch to some other agent. Anywhere between 12 and 15% of the population will have lack of this particular enzyme, the 2D6 iso enzyme of the cytochrome series, so they won't be able to efficiently convert the codeine to morphine. So they'll be what we call codeine resistant. Morphine, all of you have heard about. It comes in all sorts of forms and formulations, which is great. So you have the standard short-acting form in a tablet and in elixir. You have a long-acting form. You have a subcutaneous injection, IV injection, etc. Morphine is interesting because it goes through the liver. It is metabolized by the liver into basically two major metabolites, morphine 6-glucuronide and the morphine 3-glucuronide. And it's really, it's interesting because morphine, these two compounds that are the metabolic products, one is active and gives you good analgesic effects, and the other one, the M3G, is the one that gives you the nausea and the dizziness, and all the sort of neurotoxic effects. So, unfortunately, these two metabolites are both cleared by the kidneys. So, if in the case of someone with kidney impairment, both the metabolites will accumulate so that it'll take longer for the person to get out of those side effects. Oxycodone is a little more potent. It's a synthetic opioid, and again, it works very well, but again, in kidney disease, it will have a longer side effect, so you may need lower doses or a longer administration period. Hydromorphone, even more potent, and again, it does accumulate when you have kidney disease. At the very bottom, I have to highlight, and anytime possible, I have to communicate to everybody, do not use meperidine. There are so many other good drugs, and meperidine, or Demerol is a trade name, meperidine it has a metabolite that's actually quite neurotoxic, and it gives people a lot of confusion, delirium. It can lead to seizures when it accumulates, etc. So it's just not a good drug at all. And meperidine also is a member, a standing member on all those lists of medications that are inappropriate in elderly like the Beers criteria, stop, start, etc. Moving on, methadone. You may or may not see people on methadone. It's a very uncommon drug to be used out there because you have to have RCMP clearance, right? So methadone, more commonly used in detoxification programs, but you may see an older patient who has been managed by pain service come in on methadone. Again, it's cleared by the kidneys, so it can run into trouble when you've got kidney impairment. Tramadol, you'll see the occasional person on tramadol. I consider tramadol very similar to codeine, right? So it's a low potency narcotic. It needs to be converted to a much more active drug, so again, through the same enzyme that codeine was involved in. So again, if you have a person who doesn't have much of that enzyme, they're not going to convert it, so they're not going to get much of the analgesic effects of tramadol. The advantage of tramadol is it has this serotonin norepinephrine reuptake inhibition activity. So this is like one of the newer antidepressants. So it may have that dual effect if that's what you're looking for. So you may actually have a lower potency narcotic analgesia with adjunct all rolled up in one. I mean, it looks very attractive, but again, like many of the things that we use in older individuals, they're almost trials of one-on-one, N-of-1 trials, because none of the data extend out to our frail 85-year-olds in any of the trials that have been done so far. So again, if you think that the person needs mild narcotic, analgesia, and adjunctive therapy might be useful, tramadol could be tried. These last two at the bottom here are the really high potency opioids, so buprenorphine and fentanyl. So you see that 40 and 50 times morphine equivalents. And that's why these are the two drugs that you have to be ultra careful about. And there are similarities and differences between these two. The similarities are they are high potency. They are both in a patch formulation, which is good or bad because the patch has to be put on to be effective and kept on to be effective. So if you have someone who's cognitively impaired, etc., you want to, if they need something like this, the patch has to be put on in a place where they can't take it off, etc. Now, the difference is, if you look at the duration, buprenorphine has a duration of 7 days. That's actually an advantage in many instances, right? You just need to change the patch every 7 days. And fentanyl has a 3-day duration. Both these drugs, if you actually look at the dosing, they are in micrograms per hour. They are not in milligrams. So they're 1,000th of a dose compared to all the other narcotics that we've been mentioning. And it's because of their high potency. The other difference between buprenorphine and fentanyl is the fact that fentanyl still needs to be cleared by kidneys, and buprenorphine does not. So if you're looking at high potency narcotics and which is theoretically the best one to use in older adults, I would say buprenorphine, because many older people have decreased kidney function. So this is one formulation you don't have to worry about. The other thing about buprenorphine is it is actually safe to be used in what we call narcotic naive patients, whereas fentanyl is absolutely not safe. What I mean by that is if you're thinking that you've got a patient with persistent pain at a mild, moderate, going on to severe stage, you want to start an opioid analgesic, you would normally start with a short-acting drug because you're going to have to be monitoring fairly closely, and if they run into trouble, you want to be able to stop it and then the side effects get out of the system. Or you want to be able to titrate the dose up to the effective dose to control the pain. So you need to start with a shorter acting drug. So you have the codeine, morphine, hydromorphone, oxycodone, etc. before moving to the patch, because the patch, the onset of the effects of a patch, if you look at fentanyl with a 3-day duration, it takes about a day and a half before the drug levels are significantly high enough to have that analgesia. So you're not going to get that effect right away. So you have to start them on a shorter acting thing, figure out their total daily dose, and then calculate back to the appropriate fentanyl patch. Buprenorphine, on the other hand, certainly in the European experiences and the trials done in Europe, has been safe in narcotic-naive people. And the lowest dose, if you think they need, on average, I think it's about 30 milligrams of morphine equivalents per day, you could go directly to a buprenorphine patch once a week, and that's it. You're done. From the prescribing perspective, but you're not done from the monitoring perspective. Now, these past two slides, I'm just going to go back. You notice that I've actually put red asterisks beside some of them. So you got codeine, oxycodone, and on this one, methadone, tramadol, fentanyl. Those red asterisks represent drugs that are involved in the cytochrome metabolism pathways. Many of the drugs that we prescribe to older adults are also through that. So you have the potential of drug-drug interactions. So just be aware that if you're increasing the dose, decreasing the dose of any of these drugs, it may impact on other drug-drug interactions, or those other drugs may impact on this. So it gets complicated. So these are the things you have to monitor for. Many of them are very, very evident, and you probably know them well. So excess sedation, sometimes it's good. I can finally sleep for the first time in years, right? Sometimes it's bad. So respiratory depression, urinary retention. Respiratory depression really happens at higher doses of opioids. So it's very unusual to have that happen at onset of therapy. You're usually getting into certainly over 100 milligram equivalents of morphine per day. That's when you start getting into respiratory depression problems. Urinary retention is a little bit more haphazard. It can occur with the first dose. So it's something that we need to be vigilant about, especially in males with prostatic hypertrophy. You can really throw them over the edge. Dizziness, nausea, falls. Dizziness and nausea are much more common with morphine itself. Like I said, there is one of the metabolic products that gives rise to this side effect more often than not. The issue of narcotics and falls has been looked at many times, and there is a very strong association. If you are requiring a narcotic just to control your osteoarthritic pains, and that's the only condition you have, your increased risk of falls is probably not that much higher on the narcotics versus off the narcotics. It's when we have all these individuals with multiple problems and multiple medications, it gets messy, and the opioids, adding them in, will increase their falls risk. That's clear, but it's a known risk that is manageable. On one hand, you want to give the person comfort and perhaps increase their functional mobility. On the other hand, they may fall because they find out they've got newfound freedom, right? So where's your, it's a balancing act. Some of the uncommon side effects I've listed at the bottom, and whenever you start a new medication, you're supposed to be vigilant about anything that's happening that is noticeable. So here I've listed some of the less common things. So histamine release does occur with opioids, so they can have flushing, itching, sweating. That you see less rarely. There's a syndrome called the opiate hyperalgesia syndrome. And what that is there's no change in the person's condition. They're on a particular dose of hydromorphone, and their pain gets worse for no reason at all. It's thought that it's not necessarily a tolerance, but there may be a change in some other metabolic pathway to cause the opioid hyperalgesia. So they can actually get more pain with the same dose of their narcotic. Immunosuppression has been described. The main culprit for that is actually fentanyl and morphine itself. Male hypogonadism, which can exacerbate male osteoporosis. Muscle rigidity and myoclonus, you can see that, but mostly at higher doses of morphine equivalents. And of course, the ongoing debate of cognitive impairment and opioids. I mean, which came first? You can have cognitive impairment and pain and require opioids. And does that make your cognitive impairment worse or better? You can have delirium, post-op delirium, and a simultaneous prescription for a post-op opioid. How does that factor in? How much of the delirium is treated by the opioid because of the pain versus how much of the delirium is caused by the opioid? This is an area that's difficult to understand, and the research is not quite there yet. Constipation, major side effect, of course, opioid-associated constipation, and this is probably one of the rare instances in geriatric medicine where we have an appropriate prescribing cascade, which is prescribing something for the side effects of another thing that you prescribed. So this is where it's rare that we do have these appropriate conditions. So this is sort of a stepped approach as to how to manage opioid-associated constipations, and make sure basically you have soluble fiber, adequate fluids. Lactulose as an osmotic cathartic is quite useful, reasonably gentle, but it's not immediate, right? So lactulose takes at least 60 minutes to have its onset unless you administer it as an enema. Polyethylene glycol preparation, now instead of the big 4-liter Go Lightly drums, you have these smaller 16-gram packs, the Peglax or whatever. Those are also useful. Bisacodyl, being a prokinetic agent, can certainly be helpful. In Europe, more than in North America, they've pushed the use of these combination medications, oxycodone plus naloxone, in a 2-to-1 ratio. It seems to work in the small studies that have been published, but again, you'll have to individualize the case, because that would be one way of decreasing somebody's pill count. That if you're going to start a narcotic and you know they're going to be constipated, then a combination pill may be the answer, so that you can decrease some of the other pill counts. Prucalopride is a new drug, again, first released for use in Europe and coming to North America. I think it is available now. It's similar to Cisapride, which some of you may remember was taken off the market because of problems with heart arrhythmias and drug interactions. Prucalopride is not metabolized through the same enzyme system, so it doesn't have that bad effect, and it seems to be fairly effective as a prokinetic agent. And lastly, this magic substance called methylnaltrexone, and its trade name is Relistor. This is sort of an organic chemist's dream, right? Because you have opioid analgesics that bind to this mu opioid receptor in the gut and slows everything down. This particular drug blocks that receptor, so it displaces the opioid and allows the gut to sort of wake up. And it's very specific to blocking only those receptors in the gut and not in the brain. So the analgesic properties are there that continue, but the gut is woken up and the constipation is thus relieved. But this compound, methylnaltrexone, can only be given by a subcutaneous injection. It's anywhere between $60 and $90 a shot. It works 60 minutes after you give the injection, and it's used as a last ditch. Like everything else fails, This is the magic bullet. You get the injection, you have a bowel movement, and everybody's happy. The choir sings and patient dances and all that. Okay, substance abuse issues. Like I said at the beginning, there was a lot of press about opioid and this huge crisis that we have. And even talking to our older patients and saying, well, I want to put you on hydromorphone, which is a cousin of morphine. And they say, you can't do that. I'm going to be addicted. I don't want to be addicted. And here you have this 98-year-old person, right? And she's very concerned about being addicted to morphine for the rest of her life. He said, don't worry, don't worry. You have very low risk. And why is that? Well, psychology and physiology of pain have actually been shown to have protective effect against future addiction, because it's very different that you're running after a compound to relieve your pain or being prescribed a compound to relieve your pain versus you're going after it for euphoric effects. Right? So the last bullet here is psychological dependence and addiction are slower to develop in the course of exposure to opioid analgesics, and recreational use, they really want that euphoria state. I mean, some of us actually flog ourselves on roads and bikes and to get that runner's high. You know, we sort of produce these endogenous opioid peptides, enkephalins, endorphins, dynorphins. So some of us understand what this high is about, and that's what these substance abusers are seeking, that euphoria from using these narcotics. That's not the 98-year-old little old woman, right? So she's not seeking it out for euphoria. She's seeking medications for relief. So that's where you can tell them, don't worry, or worry much less. But if you still have worries, there are tools. There's the SOPER tool that is a 24-question thing that you ask your patient, and well, you can sort of read some of them and say, how often do you feel bored? Well, never, seldom, sometimes, often, very often. How often have you felt a craving for medication? You know, it goes on and on and on. Like, how often have others told you you had a bad temper? How often have you run out of pain medication early, and all that stuff? So if you ask those 24 questions and score them on 0 to 4, anything over a score of 18 strongly suggests this person may be seeking drugs for other uses. So maybe it's not a good idea to put them on long-term opioid use. So, to tie things up, opioids are definitely appropriate for managing chronic persistent pain and the suffering and distress that are associated with that condition. Once you've made the decision to start opioids, you have to monitor. And during the initiation and escalation of dose, that may be hourly to daily, depending on how fast you go. In the outpatient setting, you certainly need to do this weekly if you're changing doses. And you're looking at the effectiveness, which is very important, measuring response on pain scales. The side effects, and some of those side effects may appear only 3 weeks after you start. And you can certainly anticipate the constipation, so you can get going with that treatment at the initiation of treatment. And also frequent review of the goals of your therapy. How far are you going? Even though their pain is controlled less well, are they more ambulatory? Is the patient satisfied with that level of pain management? So again, a lot of dialogue between the healthcare team and the patient and family to figure out what those goals of therapy are. It's very important to document everything and communicate to everyone what you're doing, because if something bad happens, they're going to end up in the emergency room and they're going to say, what is this adverse drug event due to? And it could have been anticipated, or certainly if it's understood, then it's managed one way versus another way. Because if you've got someone on chronic opioids and they present to the emergency room a little more confused than usual, there may be a reflex action to stop everything, and then you've got an opioid withdrawal syndrome, and it's very hard to manage after that. So the more people that you communicate it to, especially families, and so they carry around active drug profiles, the easier it gets to manage these. And if you start getting confused and puzzled yourself as to where do you go next, or I need help, then certainly referral to a specialized pain center and or geriatrics, of course. We'll try and help you out with the complexity and the competing either the physical state, psychological, or the social situation, all those competing things in the mix. And lastly, that's what we want to do. We want to add life and quality of life to the years that are remaining. So there's certainly a set of references there that you can pick up. And as my parting slide, of course, on the right you have aromatherapy. This is an acupuncture as some of the tools of alternative complementary medicine in management of pain. Thank you.